Welcome to MediByte. Today, we're going to demystify endometriosis, a condition that affects millions of women but is so often surrounded by confusion and misinformation. So let's start with a number that really puts things into perspective: 18%. That's about how many women are diagnosed with endometriosis. That's nearly 1 in 5. It really makes you realize just how widespread this chronic disorder is. So here's how we're going to tackle this. First, we'll get into what endometriosis actually is. Then we'll cover the symptoms to look out for, the journey to getting a diagnosis, what the treatment and management options look like, and finally, we'll talk about living with the condition. All right, let's dive right in. The best way to understand endometriosis is to start with the fundamental problem, which, as you can see, is all about tissue showing up where it shouldn't be. Okay, so here's the core idea. Inside the uterus, there's a special lining called the endometrium. With endometriosis, tissue that's very similar to that lining starts to grow in places outside of the uterus, places it really has no business being. And when we say outside the uterus, it can be in a whole bunch of different spots. Most of the time, it's found in the pelvic area, on the ovaries or the ligaments, but it can also end up on the intestines or the bladder. And in some really rare, and I mean rare cases, it's been found as far away as the lungs or even the heart. So why is this a problem? Well, this rogue tissue still acts like it's in the uterus. That means every month it responds to your hormones, it thickens, breaks down, and bleeds. But here's the catch. Unlike a regular period, that blood has nowhere to escape. So it just stays there, causing internal bleeding, inflammation, scarring, and, for a lot of people, a whole lot of pain. This, of course, leads to the big question. How on earth does this tissue get there in the first place? And the honest answer is, we're still not 100% sure, but scientists have a few leading theories they're working with. Let's look at the main ideas. The most widely known theory is called retrograde menstruation. That's when menstrual blood flows the wrong way, backward, up the fallopian tubes and into the pelvis. Another theory is that these cells are little travelers, getting into the bloodstream or lymphatic system and setting up shop elsewhere. And a third idea is even wilder, that some cells in the body can just transform themselves into endometrial-like cells. Okay, now that we kind of get what's happening on the inside, let's talk about what that feels like on the outside. This is so important because one of the biggest hurdles with endometriosis is that its symptoms are so often dismissed as just bad cramps. But it is so much more than that. When you talk to a doctor, they're often listening for 3 classic signs. First, dysmenorrhea. And that's just the medical term for periods that are debilitatingly painful. We're talking pain that makes you miss work or school. Second, deep pain during sexual intercourse. And third, challenges with fertility. In fact, for about a third of women who have trouble conceiving, endometriosis is the underlying cause. What's really interesting is that your specific symptoms can sometimes be a clue as to where the tissue is growing. For instance, if it's on your ovaries, you can get these blood-filled cysts called endometriomas. If it's on your intestines, you might get bloating and pain that feels a lot like IBS. And if it's on your bladder, well, you might have pain when you pee or feel like you constantly have to go. And please, if you take one thing away about symptoms, let it be this. The amount of pain you feel has nothing to do with how much endometriosis you have. Someone could have just a few tiny spots and be in absolute agony, while someone else could have a much more advanced case and have hardly any symptoms at all. So I'll say it again. Your pain is real, and it is valid. So, you suspect you have the symptoms. What's next? Well, getting an official diagnosis can, unfortunately, be a really long and frustrating road for a lot of people. It's not uncommon for it to take years to get a definitive answer. The whole diagnostic process usually unfolds in a few steps. It almost always starts with a deep conversation with your doctor about your pain, your cycle, your family history. That's usually followed by a physical pelvic exam. From there, your doctor might order imaging, like an ultrasound or an MRI. But the only way to be 100% certain is through a surgical procedure. Yeah, and it's really helpful to understand the difference here. On one hand, you have imaging tests. They're non-invasive, and they're pretty good at spotting those larger cysts. But they can completely miss smaller patches of tissue. That's why laparoscopy, a procedure where a surgeon uses a tiny camera to look inside your abdomen, is considered the absolute gold standard. It's the only way for them to actually see it, confirm it, and even see how widespread it is. Okay, so you have the diagnosis. Now the focus shifts to treatment. And with endometriosis, it's all about creating a personalized plan. There is no one-size-fits-all cure. The right approach for you is going to depend on your symptoms, your age, and your family planning goals.
Generally, treatments head in one of two directions. The first goal is management through medication. This is all about relieving pain and slowing down the growth of that tissue. The second goal is more direct, surgery, to physically go in and remove or destroy the misplaced tissue and any scar tissue it's created. Looking at medications, there are a few different classes. For milder pain, you might start with over-the-counter NSAIDs, like ibuprofen. For more persistent symptoms, hormonal contraceptives like the birth control pill can be a game changer because they suppress the hormones that feed the endometriosis. And then for more severe cases, there are stronger drugs called GnRH agonists, which basically put your body in a temporary, reversible menopause to really shut down tissue growth.
Now, if medications just aren't cutting it, surgery is often the next conversation. That same laparoscopy used for diagnosis can also be used for treatment to remove the tissue. For those who are done having children and are really suffering, a hysterectomy, removing the uterus, might be an option. And in the most severe cases, that might include removing the ovaries as well, which would induce menopause.
Well, okay, we have covered a ton of information. So let's bring it all together. What are the most important things to remember when you're moving forward and living with this condition?
Let's really drill down on the key takeaways. First, this is a chronic condition, meaning it's likely something that will need to be managed over the long term. Second, and I can't say this enough, your pain is real. Third, laparoscopy is the only way to get a 100% confirmed diagnosis. Fourth, treatment has to be tailored specifically to you and your goals. And finally, there is some light at the end of the tunnel. The condition usually becomes inactive after menopause.
We really hope this explainer has armed you with knowledge and empowered you to be your own best advocate. So we'll leave you with a final thought, a proactive question to take with you. What questions will you ask your doctor?
If you found this information helpful, please give it a like and share it with anyone you think could benefit from it. And of course, make sure you subscribe to the MediByte channel for more clear and concise health explainers just like this one.